I can.
Hello, and welcome to MOASC's annual oncology billing webinar. My name is Nicole East. I'm the executive director of MOASC. Today, we have a fantastic lineup of speakers to discuss oncology billing updates and the impact to your practice. The presentation slides will be emailed to you after the webinar. If you have any questions or need anything during the webinar, please feel free to type your comment into the chat or unmute your line. First, I would like to recognize our corporate sponsors and thank them for their support of MOASC and its efforts. Their sponsorship enables us to deliver essential educational programs like this webinar today. If you have any questions for our sponsors or would like their contact information, please reach out to Christy at moasc.org and she'll provide that information to you. Now I'm pleased to introduce our first speaker, who most of you know, Bobbi Buell. She is principal for Provider Services and Reimbursement for onPoint Oncology. She's a nationally recognized expert in oncology reimbursement. She's going to go over the oncology billing updates shortly. So without further delay, I'll turn it over to Bobbi.
Good afternoon. Luckily, I'm on the same time zone for a change. Good afternoon, everybody, and welcome to this Lunch and Learn. I would like to thank MOASC for inviting me for about I don't know how many straight years, but thank you for inviting me. And I hope that you all recognize that anything that's out right now are proposed rules. They aren't, besides ICD-10, they are not in effect. ICD-10 will be coming into effect October 1st. And there are, for once in our lives, there are a lot of oncology changes. So I am going to be going to an AHA webinar next week. So I'll even find out more about how Coding Clinic, which is the supervising body over ICD-10, how they view these codes and when they think you can use them. So stay tuned for that. But today we are going to actually talk about the new ICD-10 codes, because usually I don't talk about them. I publish them in my newsletter, but I don't talk about them when I give webinars. But this is very important, so I will. And again, these are proposed regulations. I am obligated to say that CPT codes are owned and operated by the American Medical Association. They are copyrighted to them. They encourage you to buy a new code book every year. Rachel and I can tell you that probably the cheapest place to buy them is through AAPC if you can. So that's my plug to AMA, so they allow me to use their codes. So today we're going to talk about the proposed fee schedule rule, the QPP proposals, some of the drug proposals. I'm not going to talk about the prescription drug benefit today. I do have a deck on the new benefits for next year. If you would like to see them, I am going to be publishing an article in my newsletter this month about the new prescription drug benefit and smoothing. And if you don't know what smoothing is, it's a way for your Medicare patients to smooth out their payments, but there are a lot of complications involved with them, unfortunately. So if you would like to know more about that, I will also be speaking about that at NCODA and ABVCC in New York. So this is what I'm going to talk about now, the proposed physician fee schedule rule for 2025. And again, this is proposed. I will tell you the things I think may go and may leave and may stay, but that's speculation. I don't really know. CMS doesn't call me up and ask me my opinion about these things. But we did have till the 6th to comment on them. And I know ASCO commented on them, and I know COA did. I only commented on the telehealth part because I think it's so dire. And we'll talk about that in a second. For those of you who are newbies, and we may have a few newbies on the phone because Southern California is a big place and people do turn over. The Medicare physician fee schedule is based on relative values. These relative values and the geographic practice cost indices, sometimes known as the GAFs, are things that update these RVUs to your geographical area. In California, when RVUs first came out, long ago, when most of you are probably children, there were payers in California that did not use the gypsies on the RVUs in some contracts. And for us here, it's very costly. If you ever see a contract like that again, please don't sign it, because our geographical changes are very different. And by the way, they do change a lot in California in some municipalities, particularly Santa Cruz, which is not in your area. Then everything is converted to Medicare allowables, the total allowable, by the conversion factor. And the thing that has been controversial since I was born is the conversion factor. And it's very controversial every year. And for your private plans, you want to make sure that their conversion factors are higher than Medicare's, particularly what is proposed right now. And of course, I don't need to remind you, sequestration is taken out of everything in the government, including anything sponsored by the Medicare program. So here's the bad news. This is the conversion factor from Medicare, and you can see that it goes down quite a bit. And again, last year, in my infinite stupidity, I got up and said to people, you know, Medicare always changes the conversion factor for the better and blah, 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 blah. And then they didn't change it. It was changed later by an act, but CMS really can't change this formula. Even though they can change some of the data that goes into this formula, they can't change the formula. So there will have to be some sort of act passed by Congress to change this. So this, I'm going to move this out of the way a little bit. Whoops. This is, you can see here that we're down 2.88%, which is close to 3% across the board. And this is just the conversion factor change. This has nothing to do with relative values or anything else that may change in the fee schedule. And again, this is proposed. Last year, it was up around 3% also in the proposed rule. And you can see here that it went to 1.80. So you will see possibly some improvement, but I wouldn't count on, you know, a huge leap in this situation. This is, you know, there's a big chart in the proposed rule that shows how much everybody's money is going to change. It used to be that they would even show the changes, the total changes with the conversion factor. A couple of years ago, when they decided people were getting really too upset, they took the conversion factor out of this. So these are the changes, and you can see that all of us in the ologies are pretty much the same. Okay, so there's nothing that's specifically being done to cancer in terms of the conversion factor. In terms of the RVUs, nobody is getting an increase or a decrease except for family practice, because there are specific codes next year that are applicable to them that they don't expect us to use. I'll tell you about that. This is from COA Analyzer. This is a couple of weeks old, so this could have been updated, but I gave a talk to the CAN group, and this was what the data looked like. Our overall cut in oncology is about 4% according to their model. You know, whether that's a valid sample or not, I don't know. But it does tell you how much our estimates really diverge from what that one chart says. And you can see that some of it is due to the conversion factor, but some of it may be due to changes in RVUs. Okay. So that's bad news, okay? So we got to process that. And we hope that we get some kind of change where that's concerned. This is something else that isn't really very good right now. And that is telehealth. All of us have become very, very dependent on telehealth. And in some specialties more than others, but in all specialties. You know, like I had a suspicious mole and I had to show it on telehealth. So I had to like get up like this against the camera because I couldn't get an in-person appointment. All specialties are really, really, really dependent on telehealth. And for those of you who are older like me, you can remember before the pandemic what Medicare rules were for telehealth. Here's what they are. The patient may not be at home, with a few exceptions, but for the most part, and particularly in oncology, the patient may not be at home. They must be in a facility, either a doctor's office, hospital, or nursing home, or SNF, or something, okay? And that patient population that must be in a provider facility also must be from underserved areas, outside an MSA and in a manpower shortage area. Those are the only rules where telehealth, it is going to be telehealth, believe me, where telehealth will apply without congressional action. This is not something that CMS can change. It's not something that ASCO can change, or COA. This has to be a congressional act. Now, how many people don't know what's going to happen within the next month? We're going to have an election. Prior to the election, the Congress may shut the government down because of the disagreement on the debt ceiling. So you may see this never happen because Congress is too busy trying to get the government back up, or this is too political before the election. So we may not see any changes to this before the final rule due to all of this stuff. So stay tuned, but this is how telehealth will change. And again, if your practice or your hospital is very dependent upon telehealth, this is not really a good thing. Also, some of the expanded list of eligible providers who give telehealth will constrict. Most of these do not apply to us. So some of the good news in telehealth is there's only 2 classes of telehealth services. One goes on the permanent list, and people make the mistake of believing that the permanent list is stuff that will stay on telehealth after the 31st of December of this year. That's not true. They're just on the permanent list for the types of telehealth that will apply after January 1st and afterwards. There's also a provisional status, and again, the same thing applies to them. These are things that CMS is looking at putting on the quote permanent list, but may not, because they're not exactly like the things they've put on the list before. CMS is also redefining telecommunication systems. The one that is preferred and the one that really applies to most telehealth will be 2-way interactive real-time audio-visual for telehealth visits, okay? And then there's audio only. Audio only is going to only be for certain circumstances next year. It must be two-way real-time audio technology like Facebook or something like, FaceTime, not Facebook, FaceTime. And the patient is not capable of or cannot use audio-visual technology. Those are the only patients that may use that. So it's important that if you have patients that fall under this category, that you be sure to document in the record why the patient cannot use audio-visual technology, or they don't have a signal wherever they are. And that's unlikely in either Northern or Southern California, but it can happen. Or a patient can be a mental health or substance abuse patient. Again, there must be a reason why they are doing it, but it's much more lenient for those patients. And also you must see those patients within 6 months of the telehealth visit. Or some ESRD, some end-stage renal disease services, 99441 through 443 are deleted next year. So you will see how that is accomplished. Now, before you jump off whatever bridge is near you, or in California, you can just jump into the freeway. That would be just as effective. Before you get all alarmed, don't forget, we do have codes that are covered by Medicare that are for virtual services. For example, your brief check-in, that code will change next year, but that is a virtual service. One thing that I think is very underutilized by oncologists is interprofessional consults. When somebody calls you from the ER for your opinion, that is billable under certain circumstances. So there are virtual services you still will be able to bill for it. CCM and TCM and all those things are offline services totally, but you can do parts of them through telehealth if you wish. Patient navigation, the same. But, for your regular visits and things like that, if there's nothing virtual implied, you cannot do it. So these are the updates. These are the things that were requested for permanent status. You can see that there were many, many, many of them. Radiation treatment management, which was on the permanent list, has been removed because CMS believes that this really isn't, it hasn't been removed. They requested permanent status. They have provisional, radiation has provisional status, but CMS said, no, this is not something that should be done on a virtual level. Home INR monitoring, your PT monitoring, that home code will go on to telehealth. So that's something else if you monitor patients' PTs while they're on anticoagulants. Caregiver training, we have had some new codes this year for caregiver training, and there'll be even more next year, as you will see. And HIV, these are preventive medications for HIV, and they will be on the permanent. The NCD actually has come out. So that's some more about telehealth. One other good thing, one thing that oncologists have had problems with since we first started having since we first started having office-based oncology is Incident 2. And what Incident 2 means is that a physician has to be in the office suite throughout treatment. And people have had problems with this for years. And, I've been involved in fraud where whistleblowers said the doctors weren't in the office, or the doctors were out playing golf, or, the doctors were at a Medicare billing seminar, wherever they were, they were not there throughout treatment. And that has been a Medicare rule. But the good thing about virtual supervision that's really fantastic is you don't have to be. You can be on interactive audio visual technology with your office, or your office can get you on that instantly. That meaning you can't be driving around the universe while this is going on, but you can be at home and supervise chemotherapy. The other thing is they're going to permanently allow direct supervision via real-time audio-visual communication for 99211 and for services with a PCTC indicator of 5 in the physician fee schedule. The, virtual direct supervision for Incident 2 next year will only be effective until 12/31. Now this is the third time they've renewed it. So I think it's possible that virtual supervision will become permanent, but stay tuned. Other flexibilities, you used to only be able to bill telehealth for follow-on nursing facility visits as well as follow-on hospital visits. Used to be you could only bill those every 3 days. That will be lifted all of next year until the 31st of December. Same thing with this virtual supervision of residents by their attendings. The whole visit has to be virtual, but that will stay. That has been renewed now for the third time. And if physicians supervised from home or did any things from home, they were supposed to go on the PECO system, which everybody on earth hates, and enter their enrolled location address, enter their home address rather than their office address. But now they can just keep their office address, and until further notice, they don't have to register their home address. Several codes which will be added for audio-visual only codes in CPT next year. These E&M codes, except for the ones listed below, will not be covered by CMS. There are 17 new codes, and one of the tasks that we have to think about for next year on our to-do list is to see who's going to use these 17 codes. Because as you know, Medicare is still, in the dark ages. Given the similarity between these codes and G2012, remember I said that's our virtual check-in code, CMS is proposing to accept the RUC values for those, and that will do away with G2012. Plus, if these changes should use, with these changes, providers still should use E&M codes with the place of service home if this turns out to be covered. CMS is not going to cover these codes. Now, again, if Congress passed something and the AMA is really lobbying for everybody to use these codes, Congress could actually say, hey, you got to use the CPT codes. Because as you will see as I go along, my friend Betsy Nicoletti, who's one of my mentors in coding, has said this is just an avalanche of G codes this year. Fortunately, not all of them applied to us in cancer, but it's still an avalanche nevertheless. And HIPAA, not the privacy part of HIPAA, but the administrative part of HIPAA, was supposed to sponsor a single set of codes for everybody to use. That doesn't mean, that everybody would use CPT for outpatient, everybody would use ICD-10 PCS for inpatient, all of us would use ICD-10 for diagnosis, and that would be the system. But with all these G codes, it makes, if you're a coder, it makes life so difficult for you, particularly having to use different codes for other payers. Okay, that's my soapbox for today. This is for those of you who have surgeons in your practice, or if you take care of cancer patients after they have a surgery, particularly if it's a major surgery, because this will not apply. This will not apply to minor surgeries like putting in ports and things like that. Those generally don't have a 90-day global period. This is for 90-day global periods. So let's say you take care of the patient post-op, you would put a 56 on your visit, and you can actually build this G code. Obviously, this is a placeholder, not a real one, on for taking care of those patients post-op. I mean, and if your surgeon takes care of the whole thing, then they don't need to worry about this. Also, with colorectal screening, CMS proposes to update colorectal screening. They're taking out barium enema procedures and adding coverage for computed tomography, colonography, and including follow-on screening colonoscopies after positive results from blood-based biomarker tests, in addition to stool-based tests. So this coverage is expanding for your patients, and of course, none of these things have copays. Also, another expansion of coverage is hepatitis B vaccines. They are currently covered, but these don't need to be prescribed by a physician anymore. It's very much like COVID vaccine. It can be prescribed by a pharmacist. It can be prescribed by a nurse practitioner, PA, and therefore you can have roster billing for this. And again, they are going to be paid just like every other vaccine in the CMS portfolio for preventive services. One of the most egregious things, which I don't believe anybody ever adhered to exactly, is if you find out that Medicare overpaid you, you were supposed to give that money back within 60 days. Well, so few people knew about this that I'm not sure it really ever happened, which is not a good thing. Anyway, this way they have expanded that 60-day time frame. And basically, if you identify an overpayment, but have not investigated it to determine the existence of related overpayments, or just to validate it, make sure that this is right, you can complete a good faith investigation and calculate all the overpayments on 180 days, in 60 days, or 180 days after which the identified overpayment was made. So you have up to 180 days. If you do this, though, you must make a submission to the Office of Inspector General with a voluntary disclosure, and then request an extended repayment schedule. So now the requirement is 60 days, the lesser of, after the conclusion of your good faith investigation. So that's an additional 60-day, an additional 180, or 180 days after discovery. It's going to be the lesser of. So, you know, if your good faith investigation takes longer, this sort of accounts for it. But that 60-day, it would have to be within that 60-day window or 90-day window. So generally, it's 180 days. G2211, one little bulletin about that. Apparently, United Commercial is bundling G2211, so check your claims for that. They did revisit Modifier 25. You can't bill G2211 with visits with Modifier 25 for drug admin. That is still a no-no. But when a patient has an annual wellness visit, and I'm actually surprised at how many oncologists are actually doing this nowadays, an immunization or any other preventive service, it can be billed with that, just not with drug administration. Also, here comes the avalanche of G codes. These are new codes for advanced primary care services. That is a sort of an add-on codes like we have with our care management. These are monthly codes. These are not per visit codes. And these are all cool. They don't pay particularly well. I think the GPC, I saw GPCM1 pays like $10. The level 3 is the highest. Okay, and you can see here, one of the cool things is they don't have a time frame. You know, it's not like CCM where it has to be 20 minutes a month, or PCM where it has to be 30 minutes a month. There are no time frames, but these are a little bit more restrictive than G2211, for example. CMS says, we anticipate that these codes will mostly be used by primary care specialties such as general medicine, geriatric medicine, family medicine, internal medicine, and pediatrics. But they say also, we are aware that in some incidences, certain specialists function as primary care. For example, they don't say oncologists, but if you're truly being a patient's medical home, and if you're doing things like AWV, you know, the average wellness visit, then you can make a good case for using these codes. Really, with QPP, things have not changed drastically since last year. CMS feels that people are still feeling the after effects of the pandemic, so they did not change MIPS a whole lot. But they do want to phase out MIPS for the MVPs by 2029. I will tell you that this used to be 2027, so I would take that with a grain of salt. But we had one of the first 10 MVPs in oncology, so feel free to start using that one in 2025, so you're well acquainted. if you are in a shared savings program or any other ACO, they are moving to electronic clinical quality measures for the shared savings programs. So if you're in one of those, which some of us in California are, I would do that. They also recognize digital interoperability. They're going to extend incentives for ACOs to fully adopt these by 2026. Other updates, there's going to be a complex organizational adjustment for virtual groups and APMs. For those of you who are in the EOM, they didn't say anything about it being in there, but it's something I would request if I were. Updates to the components. Qualities has 196 measures. The completeness measure stayed at 75. It's totally same. Cost, they revised the cost measure scoring methodology to assess the cost of care in relation to national averages. So they're going to be benchmarking your costs next year. Also, there are 6 new activities. None of them are cancer in that cost component category. CMS proposes to eliminate activity weightings in the improvement activities and reducing the number of activities for those of you who are doing that. And CMS it changed this category to include the removal of automatic re-rating for social workers and detailed criteria for qualifying resubmissions. Again, the neutral score for no incentive and no penalty will be 75 again. And all of this will stay the same as well. There are new MVPs. As you can see, there aren't any new cancer ones, but for those of you, there are people in California that have urologists in their practice, so there is a new MVP for them. These are the proposed rules. These are the proposed rules regarding drugs. And really, I don't have much else for the OPPS. I think I took that out. I'm sorry, I probably should have. Is there anybody out there that's in a hospital? If so, raise your hand and somebody tell me. Are there hospital-based people out there? Because I took the hospital out. Okay.
Don't think so.
Yeah, there's not much new for hospitals either, really. They are not, but by the way, just to make all of you angry out there, they are getting a price increase, not a price decrease. But not for drugs, just for services. But one thing that does happen in the hospital, you may hear, let me go back. You may hear people say from some places that it's very unfair that hospitals get paid a higher rate for drug administration than offices. And that is because all drugs, 100, well, next year will be 140, right now it's 135, are bundled in to drug administration. And this is after 3 years when the hospital has a special status cost pass through. So a lot of drugs that you use, particularly all the generics, all the generic antiemetics, pain med, Lasix, all that kind of junk is bundled. So when you see their drug administration rates, remember that all this is bundled in, as well as a few minor lab tests as well, particularly CPT, CBCs, and things like that. There's a new CAR-T therapy proposal. There will be, they have had level 3 codes for preparing the cells and the patient for CAR-T therapy. These will now go to level 1 codes. They will be published in the CPT manual. I love the way they say they're valued similarly to apheresis codes. Apheresis codes have never been valued fairly. So when we see these, it may not be good news. Also, they were going to put all the gene and CAR-Ts in one big comprehensive APC or several. I don't know how exactly they were going to do it. They decided not to. So all these therapies will specifically, specifically be paid at the same formula, ASP plus 6 of everything else. Also for diagnostic radiopharmaceuticals, this is in the hospital. CMS will pay separately for diagnostic pharmaceuticals when the cost is over $630. And one thing that, one other little sort of prep message is when your patient goes to the hospital, they may, if they're going in for stuff with radiopharmaceuticals in it, they may see a bigger bill if they don't have Medigap. So this is something that your patients should be warned about. Part B drug proposals, CMS will include orally and enterally administered compounded formulas of immunosuppressive drugs for those patients who have had transplants. Blood clotting factors, CMS will say you only get a furnishing fee for blood clotting factors if the patient self-administers. These are really complicated formulas, and it is, for some of you, it's after lunch, so I don't want to put you to sleep. But basically, there have been a lot of drugs that have come out with no ASPs or negative ASPs because one product is discounted below cost. And so this time they actually published rules for pharmaceutical companies in case there is a drug either in your category or your drug has a negative ASP. One horrible thing that has been going on in the hospital, and you may hear people complain about it, is before the drug has an ASP or a WAC that isn't published, drugs are not getting paid in the hospital. And they get what they call an E2 status. And in some cases, they make you whole. In some cases, they don't. And I don't know why. But CMS has changed that, as you will see. And just like you, in 2026, they will have to give invoices if there is no WAC or no ASP. Also, we all know about the inflation rebates. We are still in our database seeing a boatload of claims that do not have JZ or JW on them. And we're also seeing drugs with multiple dose vials getting billed with JW or JZ. That's the flip side. Please remember to put for every single dose vial you use JW or JZ. If you are using, and some of the newer drugs coming out do have multiple dose vials. If you're using those, do not put that on, do not put JW or JZ on the claim. CMS may, we have seen this too, they may pen that claim. So you will have to send them the package insert saying it's a multi-dose vial. Okay. So also for the Part B inflation rebates, they will exclude 340B submitted by Medicare suppliers. Those will be excluded from the rebate program since you're already giving a rebate here. Part B, this is the inflation rebate. Again, one other thing for your to-do list is each quarter, look where you go to look for ASPs, look at the drugs with different co-payments for the patient, because that's in our benefit. And again, discarded drug refunds that the drug companies have to pay, they don't have to pay both the discarded drug refund and the inflation rebate refund. Now, as you know, Part B and Part D do have inflation rebates. And you know that 10 drugs now will be paid at the MFN. And that's I'm not going to say what it stands for, but you can take it. You can take a big guess. Anyway, so you want drug companies will not have to pay several rebates on the same dosing. Also, CMS, and they will pay Part D under AMP, which is average manufacturer's price. It will not be ASP, and it will not be, they're going to be paying the rebate on AMP, not AWP or WAC or something like that. Again, they're going to use the same. They're going to use the number of units, which is very hard to pull off Part D data. I wish them the best of luck. And they will be sending rebate reports out at the end of this year. Nobody's going to be paying any kind of rebate for inflation. So we get the benefits of that with lower copays, lower coinsurances, but the drug companies will have to pay this rebate for inflation. Again, we all know about the drug waste one. Please, 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 please don't forget to put the modifiers on. Because in a lot of cases, after the Change Healthcare thing happened, a lot of edits were taken out of your software that reminded you to do this. The rule also proposes to revise the term single-dose containers in defining that the product is eligible to include packages packaged in single-dose or single-use packages, because in some cases, the package is single-use, even though there's a bunch of stuff in there. Injectable drugs with label volumes less than or equal to 2 ml. So those are now being included rather than excluded. And for drugs contained in ampules with no discard statement in their definition. So that will change. That's something to tell your pharmacy department about. But please, please, please don't forget to put those modifiers on a claim. Okay, this is actually probably the biggest change. You can see that for many lymphomas, your ICD-10s have been changed to include in remission. Now, in remission to me means the same thing as coding for history of. In other words, the patient is in remission, in my view, and we'll have to see exactly how this comes out, but in my view, when they have stopped treatment. Now, physicians will say that a patient's in remission if they stop therapy for a while. That is questionable in my mind. So that's something that we should really follow up on with your physicians. And, whatever I find out, I will let you know, but please read the coding guidelines, for both in remission and history of. It really implies that the patient is not being treated. And the C86, this whole series changed for not having achieved remission as well as in remission. So that whole code thing changed. So check out C86 and C88. It's the same as above. And this is primary central nervous system lymphoma. This is a new coding series, a new code that we have in that series. So please check that out if you ever see it. It's fairly rare. Okay, again, new added codes for 2025. And this is some we have been waiting for a long time. Okay, first of all, these are poisoning by adverse of anti-neoplastic or immunosuppressive drugs. So if you actually have an adverse effect of these, this is a newer series, but really the biggest one is T45A. This is poisoning by an adverse effect of an underdosing of an immune checkpoint inhibitor and immunostimulant drugs. We have a lot of those in oncology. So if a patient has a bad reaction and you have to stop the infusion, or something like that, this is a very good code to use. Z17, we got a lot of new ones coming up. First of all, Z1721, progesterone receptor positive status, PR positive status. So now it was Z17.22, progesterone negative status. Z17.31, human epidermal growth factor receptors, sometimes known as EGFR. Gosh, I haven't even had a drink today. And HER2 positive receptor positive status, HER2 positive, and then EGFR with HER2 negative status. And then combined receptor status, you can see hormone receptor positive with HER2 positive status and EGFR positive, and then EGFR negative with HER2 positive with HER2. And then Z17.42. These are, one thing we've never had is triple negative breast cancer. And you can see here that that's what Z17.421 is for. Please update this because we have a lot of, we don't have a lot of drugs, but we have comparatively a lot of drugs in triple negative breast cancer. So please make a note of all of these new ones. And I would encourage you to get a new ICD code book. If you don't want to, ICD-10 codes are available for free on the CDC website, but you know, it's a lot of printing out. Oh, and then their new SDOH codes, those are the specific cancer codes. Here's my favorite one. Z59, problems related to housing and economic circumstances, that one. And Z59.7, I must have left off a digit there. I'll correct it and send it to you. Z59.71, insufficient social insurance and welfare support. Insufficient, I love this one. Insufficient health insurance coverage. I think everybody in America could have that one, but they really basically say this is a patient without coverage or without being able to get any kind of disability or any kind of insurance, and insufficient welfare support and inadequate welfare support. Well, you all on the phone know I have been weeping and moaning and telling everybody to do care coordination because we've long been asked for codes that you can use when you are not face-to-face with the patient. And most of these are those kinds of codes, with the exception of advanced care management. You do have to be face-to-face for that. But all the rest of these are kind of add-on codes. And for a long time, absolutely nobody was billing these. But I would like to show you from our database where we had about 2 million E&M patients. We had 19, and this is in a rolling year, as you can see. We had 19,000, almost 20,000 490s, which is staff care management monthly. That's a 20-minute one. For TCM is very, very popular in oncology, but this is a deceptive number. We had 4,451 of those, and with only 4,538 discharges. So I thought, well, that's weird. But as we all know, a lot of people deal with hospitalists. So you aren't necessarily the people that discharge the patient, but you're the ones who are going to take care of them. Advanced care planning for the first 30 minutes, we almost had 10,000 of those, 9.7 thousand. PCM by staff, 13,547. That is like double, more than double of what it was last year. PCM by physician, PIN, which you're going to hear a lot more about in a few minutes, 682. But look at all these patients. Now, some of them aren't eligible for PIN, but that is still very low for us at this time. SDOH screening, same thing, that's very low. But again, the patient must be indicated for an SDOH screening, so that does limit those patients. And then the E&M add-on, G2211, you can see this, that there have been 234,159. So a little over 10% of our patients are getting that. Again, I give the message about, lift this up a little bit. UHC commercial is no longer allowing this. So that number may go down over the next year, but that is being widely used, and we're glad to see it. For the next time I show these, I'll show the denial rate on G2211 because I think it would be interesting. So I'd like to thank you all. Remember all the things I told you to remember. Get an ICD-10 book. Use JZ and JW. Even on miscellaneous J codes, by the way, CMS is requiring them. Make sure you know what payer is taking what code this year. Remember, there's an avalanche of G codes. Thank goodness, many of them don't apply to us. You know, they're for mental health and different things. So those are things that are very important to look at. Look at doing the MVP. If you haven't done it so already, you can join a virtual group for that. If you think your patients are going to have problems paying for the $2,000 out of pocket in a lump sum, make sure they can opt in to smoothing. I think it always sounds like I'm talking about smoothies, but they can opt into smoothing, but they must opt in. So that's something for them to think about. And remember, open enrollment's coming up. And that is all I really had to talk about. Are there any questions? Get up here before.
Thank you so much for presenting this information, Bobbi. To the audience, if you have any questions, please feel free to type them into the chat or unmute your line and ask your question.
I know people get very self-conscious about asking questions. Please, everybody knows my email, but it is on the front of my slides. For those of you who don't get our newsletter, it's free. And Rachael can tell you some of the side benefits of subscribing to the newsletter. But, you know, it is free. We don't sell your data. We don't actually give your data to anybody, including our parent company. So please feel free to sign up at onPointOncology.com. And if there are no further questions, feel free to please email me privately if you don't want to shout out in front of your peers or whatever. And I appreciate your taking care of cancer patients. Keep up the good work.
Thank you so much, Bobbi. Appreciate it. I don't see any more questions, but if we receive any in the office, we'll definitely forward those to you. All right, so we're moving on to our next speaker. We have Rachael Willeford. She is the Senior Coverage and Reimbursement Specialist at ASCO, and she's going to cover the oncology navigation codes and what you need to know. Without further delay, I'll turn it over to Rachael.
Thanks, Nicole. Let me pull this up real quick. So as Nicole stated, my name is Rachael Willeford. I am the Senior Coverage and Reimbursement Specialist at ASCO's Care Delivery. I'm also a certified hematology oncology coder by trade and spent several years in the practice before coming to ASCO. Let's see, where's my, this would be helpful if I have everything. There we go. So today we're going to cover a few things. First, we're going to be able to identify services that address health-related social needs by the time we finish this presentation. You'll be able to recognize the reporting requirements for services and then also know how to connect social determinants of health with our ICD-10 CM codes that are associated. Before we do that, though, what are social determinants of health and what exactly is that? Because that's really been a real big buzzword lately, health-related social needs and social determinants of health, right? So social determinants of health are non-medical conditions that are related to an individual's living, learning, and working environments. They affect one's health and associated outcomes, things like social, economic, and environmental conditions that are faced by individuals and communities. The health-related social needs are affected by social determinants of health because they are those experiences and unmet needs that affect one's health and well-being, which arise out of adverse social determinants of health. So let's look at services that address these needs. In the 2024 final rule, CMS created a new code set to support activities that encourage addressing and managing health-related social needs. It's actually a code family. The result is 3 different services: the community health integration, principal illness navigation, and a social determinants of health risk assessment. The first of these services, community health integration, is initiated at an E&M visit at which a problem is addressed and for which social determinants of health needs are identified that significantly limit the provider's ability to treat or diagnose the problem. Certified or trained auxiliary personnel, which may include community health workers, then perform supportive activities under the general supervision of the initiating provider that make up community health integration services to address those social determinants of health needs. The initiating practitioner would be the billing provider, but it's important to note that there does need to be some type of relationship between the practice and the auxiliary personnel in order to report the navigational services that are provided, whether it's through direct employment, leased employment, or even contractual agreements. This applies to both the community health integration and principal illness navigation. Principal illness navigation services are similar to that of community health integration, but instead they focus on that serious high-risk illness or condition. These services are performed by auxiliary personnel that are also certified or trained, but they also require certification or training on the serious high-risk illness or condition that was addressed at that initiating visit. These personnel may include staff such as cancer navigators, mental health navigators, social workers, and also certified peer specialists in certain situations. Community health integration and principal illness navigation include many of the same activities. So auxiliary personnel may perform activities that include communication with all service providers regarding the patient's psychosocial requirements, their preferences and desired outcomes, education by building self-advocacy skills and educating the patient on how to best participate in medical decision-making. With principal illness navigation, the educational component may also include providing the patient with information on participating in clinical trials. Coordination may look like coordination with services and care transitions between not only healthcare-based providers, but also community providers. Personnel may facilitate access to healthcare, but also community-based social services. The personnel may also provide social and emotional support in order to cope with the problem addressed, their social determinants of health needs, daily routines. In addition to navigation through social and emotional support, CMS has also stated that the staff may provide mentorship and inspiration as they are really focusing on a lived experience through navigation. Also, this would also include establishing an action plan through a person-centered assessment by personnel. The social determinants of health risk assessment is used to report the administration of a standardized evidence-based social determinants of health assessment tool. Now, at a minimum, the tool that is utilized when doing this must assess for 4 specific categories, that being food insecurity, housing insecurity, transportation needs, and utility difficulties. The tool may include other items that could affect compliance and the social needs of the patient, but at a minimum, the tool must demonstrate an assessment for these 4 categories in order to report the code. I would like to point out that the intent for this code is not to be a screening tool. It's not to screen all individuals. Rather, it's meant to assess a patient with suspected or known social determinants of health needs. So there is that caveat. Next is community care management services. And we do bring this up because care management services may also be a tool used to address social determinants of health needs when it's done by clinical providers and staff. Instead of an action plan that we talked about with navigational services, the practitioner would develop a comprehensive care plan in which social determinants of health may be included in. Care is coordinated and managed with clinical staff or by the providers for chronic conditions which may be affected by social determinants of health, or it may include a serious high-risk illness. And what do those look like? Well, many oncology practices already provide care coordination for their patients simply due to the nature of the patients that they are serving. Many of these patients have multiple chronic conditions. There are 3 categories of care management services for patients who are at a significant risk of death, exacerbation, or decline. The first being chronic care management, in which patients have 2 or more chronic conditions expected to last at least 12 months. Complex chronic care management is for patients that also have 2 or more chronic conditions expected to last at least 12 months. But these patients also require moderate or a high level of medical decision making within their care. And finally, principal care management, patients have 1 high risk complex chronic care condition or complex chronic condition that is expected to last at least 3 months. And that care also requires a moderate to high complexity, usually due to comorbidities or management. Care management activities may only be provided by physicians, qualified healthcare professionals, and clinical staff. So the activities included in the services are clinical in nature, like reconciling medication, developing a comprehensive care plan. Some of the activities included in care management services, though, are very similar to that of the navigation codes, like care coordination and trying to get them to adhere to a treatment plan. It's just the focus is different. While the navigation codes are focused more on navigating that patient through care by supporting the patient, care management services are focused on the management and coordination of that patient's care. What everyone is usually interested in, the reimbursement and reporting of codes. How do we do this? First, we will go through the groups individually, and then there are some universal guidelines. The first being patient navigation services. So reimbursement that we see through here is based on national rates for the non-facility setting, which are provided by CMS in the Medicare physician fee schedule. Actual rates for your practice or practice would vary based on reporting location. I know California has several localities, so it will kind of vary for y'all. For the navigational codes, CMS used chronic care management codes as a basis for the reimbursement for the social determinants of health service codes. G0019 is reported for the first 60 minutes per calendar month of community health integration services. And then the add-on code for each additional 30 minutes per month is reported with a G0022. Reimbursement is at $80.56 for that primary code and $50.26 for each additional the add-on code. Principal illness navigation is very similar to that of community health integration, as you can see. In fact, the reimbursement is the same. They are based on the same RVU values. G0023 is reported for the first 60 minutes, and G0024 is reported for each additional 30 minutes. There are 2 additional codes in this code family that they are G0140 and G0146. However, they're restricted for behavioral health conditions only. It should be noted that the add-on codes for both community health integration and principal illness navigation, currently there's no frequency limits. So I know that sometimes these can be time heavy, depending on what you're doing. So they have not established any frequency limits for the add-on codes yet. The social determinants of health risk assessment, that's reported with G0136. This accounts for an assessment taking between 5 and 15 minutes and should not be reported more than once every 6 minutes per provider per patient. So I know that there are sometimes it may be more than one provider doing this, but only once per 6 months per patient. Reimbursement is set at $18.97 for 2024. So what are they looking at for documentation? Well, in addition to specified training required for the auxiliary personnel, CMS has provided a little bit of guidance on the specific documentation needed. Community health integration requires an initiating visit by the physician or qualified healthcare professional or a provider who can independently report is what they call it. This is typically but not limited to an E&M visit. At the visit, the initiating provider must identify the social determinants of health needs that limit the ability to treat or diagnose those problems that are addressed. The patient record should also reflect those social determinants of health needs that have been identified, and through the navigation spectrum, any additional needs that are identified within that. The time spent furnishing the activities which address those social determinants of health should be documented in the patient record, along with an actual description of the activities performed. And finally, consent needs to be obtained, and we'll cover consent in just one moment. Documentation for principal illness navigation. So in a lot of aspects, you'll see that principal illness navigation is very similar to that of community health integration. But like I said, it has a different focus. So principal illness navigation also requires that initiating visit. In this visit, the provider should identify medical necessity for that navigational service. The needs that are identified should substantiate medical necessity. So what about the patient's condition requires these navigational services? Also, a disease-specific care plan must be established by the provider, and that may require frequent revision, like kind of what we see for principal care management. If there are any social determinants of health needs that are present, they should also be included. But social determinants of health needs are not required for principal illness navigation. The time spent furnishing the navigational services for principal illness navigation should also be documented. However, the time that's spent is in relation to the serious high-risk condition, and the documentation should also include a description of the actual activities in relation to the treatment plan. So for the social determinants of health risk assessment, there's not a whole lot compared to the other 2 service codes. However, there are a few. So first, the assessment must use an evidence-based tool to evaluate for the social determinants of health. CMS has provided a few examples. We do have a resource for this that has a link to those CMS resources. The assessment tool may also be performed on or before an associated visit, such as an E&M, annual wellness visit, or even transitional care management It doesn't actually have to be on the date of the associated visit, but it's got to be in relation to that visit. And finally, identified social determinants of health needs should be documented. They may be documented with ICD-10 Z codes, which we will talk about in the second half of this presentation. So we have provided an example here just to try to see what it kind of looks like. So in our example, our patient has breast cancer and is receiving chemotherapy every 2 weeks. And at the visit, the physician recommends potential clinical trials that the patient may qualify for, but the patient expresses concern about treatment frequency because the patient's been sharing the family vehicle with the spouse who's having a lot of difficulty taking time off of work to bring the patient to treatment because, work doesn't like when you have to take off every 2 weeks. The family is also significantly strained financially due to medical bills relating to the diagnosis, and the patient tells the doctor that the stress is really affecting the marriage. So as you see here, the physician identifies that and engages the navigation team to help with not only the psychosocial issues that the patient is going through, but also educational issues. The patient needs to know about how they can participate in clinical trials because, as well as a lot of people know that clinical trial participation is pretty low. So how do we help with that? Well, this is one way. So how do we report what we see here? The physician or qualified healthcare professional would report an office visit that applies depending on what we can't just base it off of the social determinants of health and that the patient has cancer, but an applicable level of E&M along with the administration of a social determinant of health risk assessment if that physician decides to employ that, along with the G0023 when the first 60 minutes has been attained, and then G0024 for any additional time that is attained within the month. So care management services, what does this look like? So care management is split between staff time and practitioner time. So for chronic care management that is done by staff, the first 20 minutes is reported with a 99490, and each additional 20 minutes is reported with the 99439. These are reimbursed at $62.58 and $47.93. Those add-on codes do have a limit of 2 per month. For practitioner time for care management, that would be a 99491 for the first 30 minutes and a 99437 for each additional 30 minutes, which would be reimbursed at $84.55 and $59.59 respectively. Complex chronic care management is different from the other 2 categories of care management in that it is only applicable to staff time. The first 60 minutes of staff time per calendar month would be reported with 99487 and would be reimbursed at $134.15. And each additional 30 minutes would be reported with 99489, and that would be reimbursed at $72.23. Principal care management, which probably is more applicable to oncology. For staff time, this would be reported with a 99426 and a 99427 for the first 30 minutes per calendar month and each additional 30 minutes per calendar month of staff time. And that would be reimbursed by $61.92 and $47.27 respectively for those codes. And then practitioner time would be a 99424 and a 99425. That would be $82.55 and $59.92 So they can add up, especially if you have multiple patients who are performing these services for. Instead of each of these having a specific documentation, this is a code family that has documentation requirements as a whole. You need the narrative that details the need. You have to establish medical necessity, and which is kind of what you have to do for everything, right? The beneficiary has to be eligible, and also has to have consent that is documented with a discussion with the beneficiary, and acceptance that is either verbal or written, depending on how long it's been since you've seen the patient. This requires a comprehensive care plan with measurable goals. That comprehensive care plan may be implemented, revised, and does require monitoring. This is something that is not just a one and done kind of thing. This is an ongoing care plan. What's unique to this is that the patient or caregiver must be given a copy of the care plan, and that's got to be documented, as well as the time spent on the services must be documented as well. So our example here. So our patient for principal care management, sorry about that, was diagnosed with gastric cancer and is undergoing chemotherapy. And at a recent visit, the patient talked to his practitioner about financial concerns, since the patient has lost their employment, and subsequently their insurance coverage. So the physician decides to engage clinical staff to assist the patient to ensure adherence to the treatment plan. After that last treatment, the patient reports significant nausea and vomiting, which has become kind of more commonplace. I'd like to point out that depending on the practice, there may actually not be navigators on staff. And so clinical staff may actually handle some of these tasks. So this is why you see some of this principal care management. So not only does the staff schedule or help that patient with assistance and making sure that that patient stays on treatment, but also schedules the patient with nutritional providers to ensure that the patient's getting the adequate caloric intake during treatment. So we would see an appropriate E&M level that is reported. The physician or qualified healthcare professional may decide to do an administration of a risk assessment tool, and that the staff may actually their staff time may be reported by the provider with a 99426 and a 99425, depending on how much time is spent. There are a few guidelines that are universal for all of the services. First is supervision. For principal navigation codes and the care management codes, staff services that are provided by auxiliary personnel, because our clinical staff are considered personnel, they are all provided under general supervision of the provider. These services would be reported by the billing practitioner itself. So while they are they may be performed by auxiliary personnel or clinical staff, they are actually reported by the actual clinician. There are a few reporting restrictions. So CMS has adopted similar restrictions for the navigational codes as we see for care management. Like chronic and complex care management services, community health integration services can only be reported by one clinician per beneficiary per calendar month. Principal illness navigation restrictions are similar to that for principal care management. So these may be billed by more than one clinician. However, they cannot involve the same condition. Consent. So Advanced informed consent is required to be documented in the patient's medical record. The patient should be aware of applicable cost sharing, which does apply to both care management and principal patient navigation services. For chronic care management and those community health integration, for chronic care and complex chronic care and community health integration, only one practitioner can be billed for these services. The patient should also be aware of that. The patient does have the right to stop these services at any time. Consent is required only once for care management and once for community health integration, unless the patient switches to a different practitioner. Consent is required annually for principal illness navigation. It is not required, though, for the social determinant of health risk assessment. They have not specified consent requirements for that. Along with reporting services for navigation, it's also important to utilize the ICD-10 code set to indicate the conditions that affect a patient. So what are ICD-10 CM codes? Now, I know probably with this audience, we are preaching to the choir, but ICD-10 relates to the International Classification of Diseases. That is the 10th revision clinical modification. These codes are a statistical code set. They classify diagnoses and basically tell the reason for visits in all healthcare settings. How are ICD-10 codes connected to social determinants of health, though? Well, ICD-10 CMZ codes that fall in the Z55 through Z65 codes may be used to identify patients that have potential health hazards related to socioeconomic and psychosocial circumstances, which directly correspond to social determinants of health. By identifying patients with social determinants of health and then mapping these conditions to applicable Z codes, the process will hopefully lead to improved quality, care coordination, and the experience of care. So Medicare conducted a study utilizing 2019 data regarding Z code utilization among Medicare fee-for-service beneficiaries. The study found that among 33.1 million total Medicare fee-for-service beneficiaries, approximately only 1.59% had claims that had Z codes on them. So why might the utilization of these codes be so low? First, there's a real lack of awareness simply regarding the codes, which is why we're talking about them today. There's also a difficulty in determining sometimes when and how to report the code, along with sometimes a lack of internal processes to incorporate the Z codes into the workflow. There's also been a confusion as to who can and should document social determinants of health. And finally, there's been a lack of explicit financial incentives simply to use them. So you might be asking yourself, if a patient's identified as having social determinants of health, then what? What do we do? Well, they need to be connected. They need to have a Z code assigned to them. There are currently 10 categories of Z codes related to social determinants of health, ranging from education and literacy to housing and economic circumstances to even the patient's support group and problems related to that. It's important for a practice to connect the social determinants of health conditions with the appropriate Z codes. CMS has broken this down into a 5-step process. First, the practice must collect the data itself. This can be done in a variety of ways, from either health risk assessments, screening tools, simply the provider or the nurse simply talking about them, or even the patient is able to self-report these. I know a lot of practices may use questionnaires through their provider patient portal. Next would be taking that data and recording that data into the patient's electronic health record or a paper record, if that's still the way that's being utilized. Then the practice would take the data and assign the corresponding Z codes to those social determinants of health conditions. We're going to talk about that process in just 1 second. The data that we then have should be analyzed and added to reports that may be internal reports for that practice or health system, but they can also be reports for social service organizations, other providers, and even health plans. This data would be beneficial also to identify unmet patient needs. For example, what social determinants of health are the biggest issue and therefore a priority? This may even impact national public policy trends. The key is actually reporting those ICD-10 codes. So let's think back to our patient and the principal care management example. In the discussion with the patient, with the provider, the patient told the physician that they recently lost their employment and their health insurance. So in our example, the patient's probably experiencing some significant stress about medical expenses, covering rent and unemployment, and has communicated that to their physician explicitly. So since the patient has expressed practical concerns involving insurance, housing, and work, and they do have to actually say that this is what they're experiencing, these conditions and concerns can be linked to a Z code. You can find insufficient insurance, you can find instability relating to housing and problems with unemployment and the ICD-10 CM index. The codes would then be confirmed in the tabular index within the manual to ensure correct coding. Like Bobbi said, in 2025, some of these codes will become even more granular since there's additional Z codes being added. A caveat here, though, there's not always a one-to-one match, and some codes may be a bit ambiguous, or there may not even be a specified code in attendance. And what do I mean by that? Well, we have the section Z59 here. It relates to problems related to housing and economic circumstances. We've highlighted some of them here. You see there's a plethora of examples here for homelessness and housing, but you only find one for transportation and security. So while we have a way to really drill down on what the problems are related to housing, we only have one to communicate that this patient has some kind of transportation issue. This particularly demonstrates a lack of and both a multiplicity of codes, and kind of what I was talking about with there's not always a one-to-one match. Just a few reminders about ICD-10 codes. So first and foremost, code to the highest level of specificity that is supported by the documentation. Secondly, ICD-10 CM guidelines do allow documentation from other clinicians that are involved in the care of the patient to be used for social determinants of health, not just the patient's reporting provider. This allowance is specific for social determinants of health. Finally, you should also include other relevant diagnoses on the claim and in the medical record as appropriate. For example, that serious high-risk condition like the patient's care should also be reported. I do want to just point out that ASCO does have a few resources on this. We have a care management and patient navigation services comparison, along with a practice administration guide for care management services, along with coding and reporting social determinants of health. There are also a number of other resources that are available on the coding and reimbursement website that ASCO has. And I will admit, when I was in the practice, I didn't even know ASCO had resources available like this. I'd like to point out that we do have a drug waste resource, Bobby was mentioning that it's so important to report those drug waste modifiers. We have a one-pager for you for that. We also have a one-pager for G2211, and we also have regular updates on the ICD-10 CM updates, and it's specific to oncology codes by themselves. Are there any questions at this time?
Thank you so much for presenting that information, Rachel. I appreciate it. If anyone has any questions, feel free to unmute your line and ask, or certainly type it into the chat.
One addition, I deleted a page out of my ICD-10s by mistake when I ported this presentation over. I'm going to send it to Nicole, and it'll be on the website. It's just personal history of having immuno checkpoint inhibitors and things like that, but they are applicable to oncology, and there was no typo in it. So I will send them over so you guys have that additional page.
Thank you. We'll make sure to send that out to everybody who registered.
And I'll point out that the ASCO resources are completely free, and they are they're not behind a login like some of societies out there. They are free. You can go on the website, and anyone can check them out.
And they are excellent. I even use them.
I am so glad that you do.
I do, and I refer people there. I wish they would
Yes.
just go, you know, particularly contrasting care management with navigation. People are very, very, very confused about that.
Yes. So, Nicole, do you mind if I put the link to the free resource?
Oh, absolutely. You can put it in the chat, and then if
There you go.
Great, we'll include that in the recap that we send out to everyone that registered as well, and we'll make sure it's in our newsletter. Thank you for mentioning that. I love that it's free. So if we receive any questions or thoughts or comments, we'll certainly forward those to you. I don't see any questions in the chat, so I guess that concludes our webinar today. So thank you everyone for joining. I hope you found the information beneficial. Once again, if you do think of any questions or comments or whatever, you can reach out to us at moask@moask.org. And once again, thank you to all of our corporate sponsors. And this concludes today's webinar. Thank you so much.
Thank you so much, Nicole. I appreciate it.
Absolutely.
Thank you for having me.
Thank you. Yes, have a great rest of your day.
Yes, ma'am.
Thanks.